So my name's Hebe Thomas. I'm a Senior Policy Officer at Department of Health Western Australia, and my role was to project manage the Diabetes Complex Care Clinic, known as the DCCC. So the DCCC is a complex care project for diabetes type 2, and it was introduced into Western Australia to trial a new innovative sustainable solution for complex type 2 diabetes patients to get them seen out in the community.
We upskill GPs in a practice by them doing a course about complex diabetes, and then they see patients referred by their colleagues, other general practitioners in the area, but also with an endocrinologist available on site to assist with patient management.
Each of the three sort of key players have got a key role. So the Department of Health manage the contracts for the evaluation and the sort of operational service delivery side of things. We also manage the governance, so we organise the steering group, which consists of all those key players. South Metropolitan Health Service, who represented the endocrinologists who are going to be providing the support, and also there's a researcher that will be undertaking the evaluation from South Metropolitan Health Service, and then a community non-government organisation that currently delivers existing complex or type 2 diabetes services in the community and has a relationship with the local GPs. We're contracted to provide the service delivery side of things and the day-to-day operational management.
I'm Tim Davis. I'm a Professor of Medicine at the University of Western Australia. I'm an endocrinologist at Fremantle Hospital, and I'm also one of the co-leads of the Diabetes and Endocrinology Network of the Health Department.
Yeah. So 360 Health and Community are a not-for-profit NGO, and we deliver health services across the state. So we are now a statewide organisation, and we deliver both chronic condition, mental health, Aboriginal services, and also GP services. So within the DCCC project, we are responsible for the coordination and delivery of the services through the project. That means that we are involved in identifying and liaising with the GPs who may be suitable to participate in the training aspect of the Diabetes CCC project, and also then coordinating that training and ensuring that they receive the appropriate support through the endocrinologist that's working with the project. We then coordinate the promotion of the service and the marketing of the service in order to get the referrals flowing in from other GPs and the delivery of the clinic. So we've got a team who work to ensure that the clinics that are set up are actually delivered in an appropriate manner at the locations where the GPs are working.
And then South Metropolitan Health Service have got sort of two key arms, so they provide the endocrinologist support. So the endocrinologist and the endocrinology department are heavily involved and have done a lot of the stakeholder engagement through South Metropolitan Health Service executive level. And the researcher has been involved with all of those groups and on the steering group who will be undertaking the evaluation as well. So it's very important that they work very closely with the non-government organisation doing the service delivery to make sure that they are collecting the information that we need for the evaluation.
So we are trying to evaluate that at the moment by following up all the patients who have come through the program, even though they may have been given a care plan and returned to usual care. We still want to find out what happens to them, and so my unit here at Fremantle Hospital are doing evaluation of that to see whether those patients are benefiting from the program. We're principally interested in metabolic control, so glycated hemoglobin, hypoglycemia rates, changes in body weight, complexity of treatment, hospitalisations with acute conditions such as hypoglycemia or hyperglycemic states, things like that. So we want to get an idea of whether the key aspects of diabetes management improve in terms of patient outcomes.
So the project aims to take an endocrinologist out of the tertiary setting and take them into the community setting to support GPs to manage their patients, which ultimately has the benefit of better outcomes, reduces costs, and reduces the waiting list at tertiary hospitals.
The waiting lists in public hospital clinics for diabetes, in particular and endocrinology in general, are long. Some hospitals, I believe, more than 12 months. And this is an unacceptable situation.
And things are changing now. There are lots of patients in tertiary that don't really need to be there. It's a very expensive way of seeing those patients. So it's to really try and support those GPs to see the patients out in the community, which is a benefit for the patients as well. They'd much rather go to a GP centre than to a hospital if they don't need to. So it's about upskilling GPs and providing them support to manage their patients in the community.
I mean, ultimately where we want to get to is we want GPs to be referring to the right and most appropriate place, but we're obviously conscious that at the moment there's this historic wait list, I guess, at tertiary hospitals, that some of those patients may be appropriate for diabetes CCC. So where they're triaged and identified as such, we go through a process to actually try and titrate those off the wait list and into the diabetes CCC project, providing they're referring GPs happy with that process to occur. Yeah, so the wait list sits at about 1 to 2 weeks. So it's very, very quick. Essentially there's not a huge wait list. The reason for that is the service is relatively new, and the plan is always that should the wait list start to increase, we'd deliver more clinics or train more GPs. So the model is able to be duplicated upon location, upon GPs, and actually able to be replicated. So we would certainly anticipate that the wait should never get excessive, and certainly significantly less than if they're waiting for their care at the tertiary hospitals.
The project has the ability to affect policy strongly in chronic disease. I think that it mostly affects policy around patient journey. We're really trying to improve the patient journey through this project and this pilot by having patients be seen closer to home. I think there's also a lot of influence that can have around improving the relationship and the communication and integration between primary care and tertiary care. We're really breaking down those boundaries of taking endocrinologists into a community setting, which isn't often done. So I think that's improving relationships and communications within the whole of the health service. And it could be expanded in many other chronic conditions. The health system has changed a lot. We've moved much more towards this chronic disease setting, and we need to change the health system to make sure that it works with that, that fits to that, and we're providing the best service that we can to people that use the health system. So I think we really tried to set the project up well before it started service delivery. There was almost a year that was taken, 8 months to 12 months, that was taken on setting up good processes, making sure that we worked together well, having lots of steering group meetings to make sure that everyone was on the same page, everyone knew what their role was, everyone knew how that they were going to integrate between each other, to make sure that those 3 key arms of the project, the governance, the evaluation, and the service delivery were going to work well together. There was a lot of time spent through the service delivery centre with engaging with the local GPs. And then any of the problems that were experienced were always discussed at the steering group to see how we could overcome those issues. I also think using existing relationships and organisations that currently exist in that health system, and using people for what they should be used for, so making sure that we've picked, evaluated that's got a good reputation, same as the service delivery centre. I think that's contributed a lot to the success of it. I also think what's contributed to the success is that we have engaged a lot with the Queensland model and really tried to take the best parts of that model, and then we've adapted that to how it would fit in a Western Australian context.
Yeah, I think there's several things. It's bringing the specialists out of the hospital to work very closely with GPs who've received additional training. That's fairly innovative and not something that we see happening very often. Certainly where you have outreach type services from the hospital prior to that doesn't tend to be in partnership with GPs, so it is a real partnership that's going on. I think the other innovative thing is training those GPs and then continuing to support them, so ensuring that they're well supported by the endocrinologist and by the project team.
I think you need people to drive these projects, and we've been fortunate in the health network in the Department of Health that we've had good project officers that have taken this on board. We've had good liaison with GPs, and we've had a good relationship with the South Metropolitan Endocrinology Service, a specialist endocrinology service. So I think it really does require people to believe that this is a good thing, that it is worth putting the effort in. There has to be funding, and the problem with diabetes, as I mentioned earlier, is that upfront funding might seem not to be appropriate in relation to other health demands, but the benefits in 5, 10, 20 years are real and substantial.
The key things really have been having that real collaboration with both Fiona Stanley and the steering group and the evaluators and 360, having everybody absolutely from day one all going in the same direction. I think at times people go off on tangents, and it gets, and that's particularly the case if you get some money to do a pilot or a project. It can start to go off in a tangent that isn't necessarily reaching the end goal, or it is slightly altering the end goal. But I think having that whole steering group together and everybody going in the same direction has been really key to actually making it work. And I think anywhere where you're impacting, where you're sort of moving care really from a historic traditional tertiary hospital setting into the primary care sector, and I guess we're seeing that happen more and more, it either just is expected to be picked up by primary care, or you have something along these lines where it's really well supported to be picked up in primary care. And certainly having the support and doing it properly is far more acceptable to GPs and far more acceptable being the NGO involved in actually delivering those services.